a very important topic when it comes to what to say, competitive exam. A short question. Whenever a question is there from obstetric topic, there is one question from this topic. So this topic is extensively covered so that no points are missed. In detail, it is being done. So the topic is physiological changes during the pregnancy. So the very important topic. I would suggest all the aspirants to read the entire source book of whichever book you're referring for gynecology, and then go to the guidebook, because a sure question is there in all the papers from this topic, physiological changes during the pregnancy. So we will start the topic. So here you can see the trimester changes. So the first thing is, when is the first trimester, and when is the second trimester, and when is the third trimester. The first trimester is 0 to 12 weeks. 0 to 12 weeks. When we calculate with respect to weeks, it is 0 to 12 weeks. And second is from 13 to 28 weeks. 28 weeks. And then third is from 29 to, so this is first, this is second, and this is third. Okay. So third is from 29 to 36 weeks is considered. And after 36, once 36 weeks is attained, it is called as term. The pregnancy has reached term, and then it can continue till 38 weeks, till 40 weeks. Okay, so this is the normal first trimester, second trimester, and third trimester division of weeks. And then now, when it comes to physiological changes in pregnancy, so in pregnancy is a, first of all, we have to understand pregnancy is a physiology. So it is a basic physiology. It is not a pathological state. So whenever there is a physiology, when we tell pregnancy as a physiological state, then obviously the changes that occurs during all three trimesters will be physiological, and the changes occurs in anatomy. There are three aspects which where the changes occurs: anatomy, physiology. Even though the topic is physiological changes, so what are the normal changes that occurs in anatomy, in physiology, and biochemical? So the entire topic will be discussed under this. So the changes is anatomical, physiological, and biochemical. And also this changes, why it occurs. The main purpose of pregnancy is to give birth. So it is to meet the demand of the fetus. The physiological change is to meet the demand of the fetus, one, and then to maintain the pregnancy, to continue the pregnancy. And also after the delivery, what and all changes occurs, the body is preparing, the female body, the pregnant women body is preparing so that there is no any problems after the delivery. So all the changes are because for the fetus and after the delivery, so that both fetus and mother is safe. So these are the this is why the changes occurs. Now it can be explained, the physiological changes can be explained under few headings. So the first one will be the genital organs. So what are the anatomical changes, the physiological changes in the genital organs, and the breast changes. And this change is mainly because why it is preparing for lactation. The preparation for lactation occurs since the beginning of pregnancy itself. And cutaneous changes. Cutaneous means skin. What are the skin changes? And then weight gain. What are the usual, what is a normal weight gain in a pregnancy? What is abnormal? And what is the range? All that will be discussed. And body water metabolism. So what is the changes in metabolism related to water, body water? And hematological. What are the blood changes? And cardiovascular system. CVS, what are the changes? Metabolic changes when it comes to entire metabolism of the body, what is the change? And systemic changes. In the systemic changes, various systems of the body will be discussed. And the questions are asked from any part of the topic in this. So there is a scenario where systemic changes is ignored so that it is not asked, or the tendency is to ignore any systemic topic like that. So systemic changes. So, but this is also important. So whatever, all these 9 topics which will be discussed now are important, and any question can come from any of the 9 topics. So starting with genital organs. So vulva. So what are the vulval changes? So it is edematous. So wherever you see there is hypertrophy and hyperplasia. This is two words that you come up in the physiological changes. Hypertrophy, that means the cell is becoming bigger, and hyperplasia, there is multiplication of cells. So these are the two important words that you come up in this topic frequently. So vulva is edematous and it is more vascular, so more blood supply is there, and you can see superficial varicosity if it is in a multipara. Multipara means who has given birth to more than one fetus, live birth. And labia minora is pigmented and hypertrophied. So these are the changes in vulva. Next, coming to vagina. Vagina, again, hypertrophy, edematous, and more vascular. So these terms, you will come across everything. All over the topic, you will be hearing these words: hypertrophy, hyperplasia, edema, and vascularity, increased vascularity. And Jacqueminier's sign, or it is also called as Chadwick's sign. Chadwick's sign. Chadwick's sign. So this is because of, it is a dusky hue or a bluish hue or discoloration, which is seen in vagina, and this is due to this increased vascularity, increased blood supply. So there is there is venous congestion which is happening, and that is why there is a blue discoloration, and that is called Jacqueminier's sign. This will come again in the topic diagnosis of pregnancy. So this is one sign through which a pregnancy can be diagnosed in early months, early weeks of pregnancy. Next, increase anterior vaginal wall length and secretions of vagina. Vaginal secretion will become copious. Copious means profuse and thin and curdy white, which contains exfoliated cells and bacteria. And one change, important change that becomes is the vagina becomes, the pH reduces. pH reduces and becomes acidic. The pH reduces and becomes acidic. Why it becomes acidic? Because you have to understand there are three hormones which plays a role in physiological change. First one being estrogen, second one being progesterone, and beta HCG. These are the main hormones. Along with this, there is human placental lactogen, so HPL. So these are the four hormones, and mainly these three are the hormones which are responsible for the physiological, the hormonal influence throughout the pregnancy. Mainly are estrogen and progesterone. So anywhere, whatever change is seen in in the pregnancy, the related hormones which are working behind is estrogen and progesterone. So high estrogen, what it happens? It is a hyperestrogenic, hyperprogesterone state. Both estrogen and progesterone is increased, and once the labor sets in, it starts dropping. So you have to, throughout the pregnancy, it starts increasing estrogen and progesterone. So because of high estrogen, the lactobacillus acidophilus, which is there in the vagina, it starts converting the glycogen into lactic acid, and there is enormous number, there is multiplication of lactobacillus, and what happens? Lactic acid increases. So once lactic acid increases, the pH of the vagina becomes acidic, and what it makes, so always the physiological change, why it is happening? It is to protect the fetus, protect the mother. So here, why it is happening? It prevents the multiplication of pathogenic organisms, so that there is no infections happening. So once infection sets in, it is it is not a good sign for both mother and fetus. So to prevent infections, this is the physiological change that happens. And then the cytology, when cytology for the tissue is taken, what is seen? It is navicular cells are seen. So navicular cells are hypertrophied cells with elongated nucleus. So those cells are seen, and along with lactobacillus. So these are the changes that occurs in vagina. So here you can appreciate the bluish discoloration here, the vaginal vault. So whenever for examination, vagina is examined, so the bluish discoloration is seen, and that is because of the more vascularity, and it is also called as Jacqueminier's sign or Chadwick's sign. Next, the changes in uterus. So uterus being the main organ which is the place where the fetus lives. So obviously there are enormous changes that happens in uterus. So let's see what happens in size of the uterus. So when it comes to size, it is length and weight and capacity. So what are the main changes? So you have to see here, there is tremendous change that happens in length, weight and capacity of the uterus. Why? It is to give nutrition to the fetus, to the growing fetus, to give space, to give nutrition. All that is from the uterus. So the normal length of the uterus being 7.5 centimeter, when at term, that is after 36 weeks, what happens? The length is around 35 centimeter. 35 centimeter, and weight being 60 gram in a normal non-pregnant women, and in a pregnant state at term the uterus weighs around 900 to 1000 gram. 900 to 1000 grams. So these I have always told, whenever there are any values, it is very important, because these values are more difficult to remember. That is why it will become a probable question, because your examiners doesn't want you to answer. They want you to answer wrong answer. So always values, wherever it is there, just remember. Don't get confused. Just remember, recall in the exams. So, and capacity. 5 to 10 ml is the normal capacity of the uterus, but it becomes 500 to 1000 times more capacity of pregnant. At term, it becomes more than 500 to 1000 times capacity. Why? The main thing is, it is to protect the fetus, to give nutrition to the fetus, to maintain the pregnancy, so that the fetus is growing in the uterus. Now, the changes in uterus can be explained under body of the uterus, isthmus of the uterus, and cervix part of the uterus. So we'll start with the body of the uterus. So what are the changes? So again, I told you the terms that should come to your mind is hypertrophy and hyperplasia. So hypertrophy, here you can see the enlarged cell. So this is a normal cell, this becoming enlarged as hypertrophy. And here you can see hyperplasia, the number of the cells have increased. So both these occurs in the uterus, and this is not pathological. This is all physiological. And enlargement of uterus due to hypertrophy and hyperplasia. And one more thing that happens is stretching. And why stretching occurs? It is because of the growing fetus inside the uterus. So that is why stretching occurs. So uterus is enlarged because two reasons, and hypertrophy and hyperplasia, and then stretching. Then muscle fibers. These are the important changes that occurs. So here you can see the arrangement of muscle fibers. So there are three muscle fibers: outer longitudinal, inner circular, and intermediate. So outer longitudinal, it is hood-like arrangement, which is seen near the fundus of the uterus. So this is outer longitudinal. Inner circular is scanty, sphincter-like arrangement around the tubal orifices or the openings. So tubal orifices and internal os. So these are minutely arranged inner circular fibers. The main fibers which come into picture in pregnancy is intermediate, thickest and strongest, and they are in the form of crisscross. Okay, so crisscross, you have to remember the terms. So whatever is in red, you have to remember, because these are the questions, probable questions. Crisscross form, blood vessels run through it. Here you can see these are fibers. These are fibers, and there are blood vessels. So this is blood vessel. So again, there is blood vessel runs through it, and opposition of two muscle fibers. So what happens? Pregnancy, there are few contractions that is happening throughout pregnancy. We will see what are those contractions. And when labor is there, there is also severe contractions that happen. So when contraction is happening, the muscle fiber causes opposition. That means they're coming together and going back, coming together and going back. And when that is happening, this blood vessel is occluded, and then blood supply for some time is stopped, and that is why it is called living ligature. Ligature means tying. Okay, or where do we do ligature? Where there is blood flow is there, we have to stop the blood flow. Ligature is done. So here, without externally doing anything, internally itself the blood flow is stopped, and that is why it is called living ligature. And which is the living ligature? It is the intermediate muscle fibers or myometrium. Myometrium is the living ligature. This is a frequently asked question. So which part of the uterus is called living ligature? It is myometrium. And figure of 8 form. Which muscle fiber has figure of 8 form? It is intermediate muscle fiber. And why they form the figure of 8? It is because of the crisscross formation of the muscle fibers. Now, vascular system in the uterus, what it happens? So, uterine and ovarian arteries are supplied equally. So, what happens in non-pregnant state? Actually, the entire genital organ, it is supplied more by uterine arteries, less by ovarian arteries. So, but when a woman is pregnant, what happens? Uterine and ovarian arteries are equally contributing the blood supply to the uterus, and spiraling of the arteries occurs, and it occurs maximum at 2 weeks, and then they straighten out. So the spiraling of arteries is occurring, and uterine artery diameter, it is doubled. The blood flow increases by 8-fold at 20 weeks. And why it is occurring, why all this is occurring? It is always because of the hormones, and the hormones in the picture is estrogen and progesterone. Next, the veins. What happens to veins? So artery diameter is doubled, so veins are also dilated and valveless. And lymphatic channels, numerous lymphatic channels open up in the uterus. And vascular changes, where is the vascular changes maximum? Where is the vascular changes maximum? It is in the placental site of the uterus. Placental site of the uterus. Why? Because there is fetus and there is the maternal site and the fetal site. So which is the connecting part? It is the placental site, and that is why the vascular changes is maximum in placental site. And the weight, as discussed earlier, of the uterus, it gains around 900 to 1000 grams at term. This at term, you should remember, it is not that any time during the pregnancy it is 1000 gram or 1 kg. No, at term it is around 900 to 1000 grams. And shape of the uterus, very important, how the shape of the uterus changes. In a non-pregnant woman, we all know it is a pyriform shaped. Uterus is pyriform shape. Pyriform means it is like this. Okay, so but what happens in the initial weeks? It is pyriform still, but by 12 weeks, what happens? It becomes a little globular, and by the time 28 weeks are over, it comes back again to either pyriform or ovoid shape. And after 36 weeks, once it has reached 36 weeks, the uterus shape is spherical, round. Okay, so here you can appreciate the weeks. You have to remember at what weeks what is the shape. So pyriform in the early months till 12 weeks, and globular is after 12 weeks it starts becoming globular, and by 28 weeks the shape of the uterus is pyriform or ovoid, and spherical beyond 36 weeks. After 36 weeks the shape of the uterus is spherical, and these are all physiological changes. So these are the normal changes that you have to see in a normal pregnancy. Okay. Next, position of the uterus. So what happens in pregnancy? The uterus becomes anteverted, exaggerated. So up to 8 weeks it remains anteverted, and this anteverted position, what it causes? It causes increased frequency of micturition. Because enlarged uterus lies on the bladder. It is causing the pressure on the bladder, and that is why initial weeks the pregnant women complains about increased frequency of micturition. So there is increased urination, and after this subsides. Why? Because the uterus becomes erect after 8 weeks. So after that, at term, the later months of pregnancy, at third trimester, again the frequency of micturition rises because of the pressure of the grown fetus on the bladder. So the long axis, so after 8 weeks, then uterus becomes erect. Long axis conforms to long axis of the inlet and held firmly against the maternal spine. And in multipara, what happens? Even after 8 weeks, because of lax abdominal wall, it remains anteverted. So in a primigravida, this erection or uterus position becoming erect happens in a primigravida, more in primigravida. And there is lateral obliquity, and uterus is dextro-rotated. Dextro means right. So uterus is rotated on the right side. That is why most of the changes that you see, it is on the right side. For example, ureter is on the right ureter. If there is any change that comes up, it is on the right, because the uterus is rotated towards the right, and cervix is rotated to the levo-rotation. Levo-rotation means left side. Cervix is rotated to the left. So in pregnancy, uterus is dextro-rotated and cervix is levo-rotated. Now, what are the changes in peritoneum that occurs? Peritoneum proportionate relation with growing uterus, and that also increases with growing uterus. Uterosacral ligaments and bases of broad ligament rise up to the level of pelvic rim and deepens. The pouch of Douglas gets deepened, and lower lateral levels uncovered by the peritoneum. So there is no peritoneum in the lower lateral walls, and filled by loose and vascular connective tissue. So these are the changes that happens in peritoneum. Next comes Braxton Hicks contraction. So this comes in the part of uterine changes. So what are Braxton Hicks contraction? Braxton Hicks contraction. So these are irregular. Contraction means something that is something is contracted inside the uterus. So what is that? And these Braxton Hicks contraction is irregular. So this is very important. So this can be formed in the form of except question, all of the above, none of the above. So that type of questions can be formed, or they can give a statement of definition of Braxton Hicks contraction and one more statement of definition of normal labor contraction. So they can ask which is true. They might give the statement one is wrong. The Braxton Hicks contraction statement can be wrong. So very important to know what is Braxton Hicks contraction. So it is irregular, infrequent. That means it is not frequently occurring. It is not frequently occurring, and it is not regularly occurring, these contractions, and it is spasmodic, and it is painless. Even though it is spasmodic, it is painless. There is no pain, and without any effect on the dilatation of cervix. And that is how you will differentiate Braxton Hicks contraction from a true labor pain. Now, it is named. Why the name Braxton Hicks? It was Braxton Hicks, this person, who told about the entity about this contraction. Now, what are these? These are spontaneous contractions of uterus, which occurs in the early weeks of pregnancy and felt during the bimanual palpation, and abdomen palpation. So when you see it is felt during bimanual palpation and abdominal palpation, that means only during examination. That means the pregnant women is not feeling it. The pregnant women is not conscious about the contraction. The uterus is firm at the moment, and then again it becomes soft. Whenever there is a contraction, there is a little firmness, and then once the contraction is released, there is a softness of the uterus. And it can be excited, even though it is spontaneous, it can occur any time. Otherwise also it can be excited by rubbing the uterus. And the patient is not conscious. The patient is not conscious of this contraction. And that is one, differentiating point from the true labor contractions and Braxton Hicks contraction. And this, what happens in true labor contraction, this increases in frequency. The same Braxton Hicks contraction increases in frequency and intensity near the term. And this causes discomfort to the pregnant women. And that is when it can be told that, okay, the true labor contractions can start. And this is the intensity continues, and this combines with the true labor contraction that way. And it is absent in abdominal pregnancy. Abdominal pregnancy is the type of ectopic pregnancy. And ectopic pregnancy means what? A pregnancy which is occurring outside the tube, outside the normal tubal pregnancy. Or outside, fertilization is occurring outside, and the implantation of the fetus or the zygote is occurring outside the uterine cavity. So tubal pregnancy is also ectopic, but abdominal is the usual site is peritoneum. Peritoneal cavity. Peritoneal cavity is the abdominal pregnancy site. So one of the differentiating feature of abdominal pregnancy, how to diagnose a abdominal pregnancy and normal pregnancy, is Braxton Hicks contraction is absent in abdominal pregnancy. And transient fetal hypoxia. So whenever there is a contraction happening, so there is a low blood supply that is happening to the fetus, and that is why there is a fetal bradycardia, low heart rate of the only during the contraction. And once the contraction is resolved or it comes back to normal, the normal blood supply happens to the fetus. Now, here you can differentiate between Braxton Hicks and true labor. Braxton Hicks, it is not regular and it does not get closer together. So there is a gap between two contractions, whereas true labor, it comes regularly and it gets closer together and it remains for 30 to 70 seconds long, and then may stop when walking or resting. This Braxton Hicks contraction, it will also stop when the position of a pregnant woman is changed. The Braxton Hicks contraction will change, but a true labor pain or a true contraction, it will continue. Excuse me. It will continue no matter what is done. Change of position, anything, it will just continue. And the Braxton Hicks contraction weak and it doesn't get stronger, and it changes between again strong and weak. It can the intensity changes, and it because it is infrequent and irregular, whereas true labor contraction, it goes on increasing in intensity. And that is how you will differentiate. That is how you will know, okay, true labor contractions have started. The intensity increases. Why? Because to expel the fetus out. And usually felt in the front, that means in the abdomen, whereas true labor pain. So when normal labor is done, that will be dealt. So true labor pain, it starts in the back and then it moves to the front and it radiates to legs too. So there is complete pain in the lower abdomen and extremities. This is how you differentiate from Braxton Hicks and true labor pain. Next is isthmus. Now coming to isthmus, there is a major change in isthmus that is happening. That is during the first trimester, isthmus again hypertrophies and elongates. The length of the isthmus increases about 3 times its original length. Remember the number 3 times. The question can easily be formed. How many times the original length isthmus is elongated during the first trimester? It's 3 times, and it becomes softer. Isthmus becomes softer. And then here you can see the anatomical internal os and histological internal os. So later, both of them forms the lower uterine segment. And this is very important to assess the progress of the labor. And that is why isthmus is very important part when it comes to pregnancy. And also isthmus is the one which holds the fetus inside, and it acts as a sphincter. So that the fetus is not expelled out. So it acts as a sphincter, and during labor, so that is why if there is any anatomical or physiological change in the sphincter, the continuation of the pregnancy becomes difficult. So that is why the anatomical and physiological importance of isthmus is very much during pregnancy. Okay. Next is cervix. Now again cervix, the same, hypertrophy, hyperplasia, and there is something called a softening of the cervix occurs, and that is called Goodell sign. Again will be discussed in diagnosis of pregnancy. So on examination, there is cervix becomes soft, or cervix is examined as a soft part, and that is called as Goodell's sign. And other changes is effacement of the cervix, which happens, and copious, the secretion of the cervix is copious, again profuse, and tenacious. Tenacious means sticky, and forms thick plug. Thick plug seals the cervical canal, and length is unaltered. So always remember, the cervical length is not altered. It is the isthmus part of the uterus that is altered. The cervix remains the same, and bulky cervix, it is just softened. It is not altered. The length remains the same. And one more change is cervical erosion occurs, and that is a normal physiology. For cervical erosion is a pathological condition in a normal non-pregnant women, but in pregnancy it is a physiology, cervical erosion, and all these changes will revert back once the delivery or once the child is given birth. So after delivery, the postpartum, everything comes back to normal, and that is why it is called physiological change during pregnancy. And the cervix is also bulky. Next, fallopian tube. What happens to fallopian tube? The total length is increased, and not very much increased, somewhat increased, and there is congestion of tube because of the increased vascularity, and there is again hypertrophy and flattened epithelium. The epithelium of the fallopian tube becomes flattened, and there is few decidual reaction. Now, what is decidual reaction? Decidua means the pregnant endometrium. Endometrium, which is in pregnancy, it is called decidua. So also the epithelium of fallopian tube also, or the membrane of fallopian tube also undergoes decidual reaction. The meaning is reacting to the estrogen and progesterone. So the hormonal changes, the reaction to the hormonal changes, and the change in or metaplasia or whatever changes occurs in the shape and size of the cells, that is called due to hormonal changes. That is called as decidual reaction. And uterine end of the fallopian tube rises up. And then fimbrial end held up by the infundibulopelvic ligament, and then vertical by side of the uterus. So this goes to the side of the uterus, and then at term what happens? Lower end of upper one third of the fallopian tube also comes down. Why? Because fetal weight. Next, what are the changes in ovary? So ovary, we all know corpus luteum is formed, and corpus luteum remains till the 8th week. Okay, it starts growing until 8th week, and corpus luteum is the one in the initial pregnancy stage, which is responsible for the beta HCG and estrogen, progesterone. The hormones are all supplied from the corpus luteum, and after that it is taken up by the, after corpus luteum regresses, the function is taken up by the placenta after corpus luteum. So the corpus luteum in the ovary, what happens? The maximum size at 8th week, it becomes cystic, and there is 2.5 centimeter size. And what happens? Initially it is bright orange, okay, and then it becomes yellow. And yellow is the part when it is called luteum. Luteum meaning is yellow, and then it becomes pale, and then it becomes whitish. Pale means whitish, and that is why when the regressing corpus luteum is called as corpus albicans. Albicans means white. So the pale corpus luteum is called as corpus albicans. And regression is due to reduced HCG. Once HCG drops down, the placenta is, because placenta is the one which is substituting and producing estrogen and progesterone. So once the placenta starts developing, once the placenta starts growing, so the corpus luteum's work is done by them. By 12 weeks, the work is done, so it starts regressing. So 12th week, there is colloid degeneration and then calcified. The corpus luteum is calcified at term. So hormone inhibits follicle ripening. The hormones from the corpus luteum also inhibits the follicle ripening. So what happens when there is follicle ripening? There is no maturation of follicles. When there is no maturation of follicles, what happens? There is no menses. There is no menses occurring. So which is the one part which is responsible for cessation of menses during pregnancy? It is corpus luteum from the ovary. And then ovarian and uterine cycles are suspended, and when ovarian and uterine cycles are suspended, there is no menses, and that is why the pregnancy is continued. So control formation and maintenance of decidua of the pregnancy. Next is breast changes. So we finished with the first part, that is genital organs. Now we come to the breast changes. Now breast changes, the volume increases from 293 ml to 381 ml to 398 ml. And then the common changes are the sore breast, darker and larger nipples. So there are changes in the nipple, changes in the areola, and changes in the fatty tissue. Adipose tissue starts accumulating, and that is why the weight contributed in pregnancy, which is also from the breast, and growing breast, and leaking colostrum and discharge. So this is one of the important sign in a woman who has not given birth and who has not at all lactated. So this is an important sign of pregnancy, where there is colostrum production and there is leakage or discharge of colostrum. So in a primigravida, the size increases. The why primigravida is put here? The maximum changes that is observed is in a primigravida. In a multipara, the changes is not appreciated that well. So a breast change maximum it is seen in a primigravida, the first time pregnancy. So size increases in size. Again, there is hypertrophy and proliferation of ducts and alveoli, and there is hypertrophy of myoepithelial cells, and bluish veins under the skin are seen. And there is something called axillary tail, and this axillary tail becomes enlarged and painful during pregnancy, and there is striae seen in the breast. And what are the changes in nipples and areola? So larger, erectile and deeply pigmented nipples. Montgomery's tubercles. These are small tubercles which occurs around the nipple, and this is present, but it is not seen in a normal non-pregnant women, but it becomes more visible during pregnancy. And moist and healthy, and secondary areola is seen. Also, there are changes in the lobules and ducts. So the ductal changes, the hormone responsible is estrogen, and the lobules, changes in lobules of the breast, it is lobules changes, the hormone responsible is progesterone. And secretion is colostrum. 12th week, the colostrum appears and it is appearing as a sticky secretion. 16th week, it becomes thick and yellowish. So these are the changes in breast. So here you can see skin. So what are the cutaneous changes? So very important, frequently asked question from this part, cutaneous changes. So the first one is chloasma gravidarum. This is a dark pigmentation. You can see here pigmentation, and this is well appreciated in the cheeks, chin, and nose part of the female face. So pregnant women's face, and that is called as chloasma gravidarum. Next is linea nigra. Linea nigra is a linear line that occurs, and all these changes are responsible mainly for estrogen hormone. Why these changes occurs? It is due to estrogen hormone. And then you can appreciate the striae here, striae. So this is striae gravidarum. It is dark color pigmented, and this is during pregnancy, it is very dark, and after pregnancy, it becomes whitish, and these are scar tissue because of the stretching of the abdominal muscles and skin, and it is striae albicans. So after pregnancy, the striae gravidarum changes, or after nearing term, it changes into striae albicans. And then this is vascular spider, and all these changes, why it is estrogen and progesterone. And there is palmar erythema, so increased congestion. Okay. So these are the cutaneous changes. Next, what is the change in weight gain? What are the changes? So initially there is weight loss. Especially in cases of hyperemesis gravidarum. There is initial weight loss and followed by weight gain because of the growing fetus and also maternal nutrition. So last 2 weeks, the weight gain becomes static. That means it stops. The gain stops, and total normal average weight gain in a women, pregnant women is 11 kgs. Around 11 kgs a pregnant women it is a normal average weight gain seen in a pregnant woman. And the contribution trimester wise is, first trimester there is gain in 1 kg, and second trimester it is 5 kgs, and third trimester it is again 5 kgs. So 10 and 1, 11 kgs is the average weight gain. And what is the contribution of each part in weight gain? So fetus contributes around 3 kgs. So the average birth weight is around 2.5. So we can consider 3 kgs contributed from the fetus, and placenta is about 600 grams, that is 0.6 kg. Liquor amnion, the amniotic fluid is around 800 grams or 0.8 kg. And uterus is about 0.9. We had discussed earlier, it is 900 grams to 1000 grams, around 1 kg. It contributes the uterine weight. And breast weight, as I told you, there is increased amount of adipose tissue and enlargement of the ducts and lobules. So it is around 400 grams. And fat and protein accumulation, this will be discussed again in metabolic changes. So there is more than protein, there is increased fat deposition during pregnancy, and that is around 3.5 kg. So here you can see the maximum contribution for weight gain during pregnancy is fat and protein accumulation. And then maternal side, only maternal, it is extracellular fluid that is 1.3 kg, and blood volume 1.3 kg. All these will be discussed under body water metabolism and circulatory changes. Okay, so these are hematological changes. So this is the contribution. So what happens? There is rapid weight gain and stationary of the falling weight. So initially there is weight loss, so that becomes stops, and then there is rapid weight gain. And BMI, always the weight gain is related or is calculated in a pregnant woman related with the BMI of a pre-pregnant state. Pre-pregnant state, and normally allowed is, for a normal BMI, it is around 12 kgs. Okay, for normal BMI. For a obese BMI, that is more than 30 BMI, the allowed weight gain is only 7 kgs. So in a obese women or in a obese pregnant women, it is always, you should always be advising to gain weight only around 7 kgs, because the complications in a obese pregnant women is a lot. So that is why, to control the complications, the minimum or the maximum weight gain that can be advised is 7 kgs. And in a underweight, the weight gain can be around 18 kgs. It is normal to gain around 18 kgs. So this is the weight gain part. Now coming to body water metabolism. So what happens to the body water metabolism? So here you can see around 6.5 liters is accumulated in the body, and that is why, because there is retained water, there is retention of water in the pregnancy. And fetus, placenta and amniotic fluid, it contributes around 3.5 liters. And there is hypervolemia. Pregnancy is a hypervolemia state, and there is also retention of sodium, potassium and water. So the total contribution is around 6.5 liters. And why it occurs? Why? The reason is osmoregulation. There is, and again, estrogen, progesterone hormones, and renin-angiotensin activity. Renin-angiotensin aldosterone, RAS activity. This is the one of the contributing factor for the retention of water. And aldosterone and deoxycorticosterone, and arginine vasopressin, or it is also called as ADH, antidiuretic hormone. So these are the contributing factors for the retention of water. And also ANP, atrial natriuretic peptide. Thirst and ADH secretion, it is increased. And osmotic threshold resetting occurs after 8 weeks. Vasopressinase from placenta. So even though the ADH is increased, it is somehow controlled, and that occurs. Why? Because there is a hormone or an enzyme which is secreted from placenta, vasopressinase, which regulates the secretion of ADH. And there is polyuria in the early months, and after that it becomes static. And atrial and brain natriuretic peptide is secreted. It is more in the pregnant women. And how it acts? It acts as a diuretic, it acts as a natriuretic, and it acts as a vasorelaxant. And it is antagonist. This ANP and BNP are antagonists to renin-angiotensin aldosterone mechanism. Next is hematological changes. Again, cutaneous changes and hematological changes are the mostly asked questions, usually asked questions. Also CVS, cardiovascular changes. These are the three main part where more questions are asked, but still I am suggesting the aspirants not to neglect any part. All the parts are important. Now, blood volume, what happens? Obviously, it is increased. Blood volume is drastically increased. From 6th week, the rise starts 40 to 50% by 30 to 32 weeks, and it becomes static. And plasma volume increases by 50%. So very important. Plasma volume increases by 50% up to 1.25 liters. Now, RBC and hemoglobin, 20 to 30% it increases. 350 ml is increased. And why it increases? Because there is high oxygen demand from the fetus end. And from 10 weeks, this rise starts. And it is also enhanced by the iron supplements which is prescribed to a pregnant women. But there is hemodilution. Even though RBC and hemoglobin increases, there is hemodilution. And why? It is because the plasma volume is more compared to HB, hemoglobin, HB percent. Okay, even though or RBC, even though the mass is increased, it is more plasma volume is more compared to HB, and that is why anemia anemia is seen in pregnancy. So it is pregnancy is a hemodilution state. So even though we say that HB increases, RBC increases in pregnancy, but plasma volume is relatively higher, and that is why HB concentration in the blood is reduced because of the plasma volume is high and hematocrit is reduced, low. So these are the changes. So plasma volume is increased, blood volume is increased, red cell mass is increased, whereas hematocrit reduces. Hematocrit reduces. Why? Because plasma volume is high. When plasma volume is high, hematocrit obviously reduces. So hemodilution advantage. What is the advantage of hemodilution? Optimum gaseous exchange between maternal and fetal secretion and supine and erect posture. This is more pronounced. Blood loss adverse effect is blood loss adverse effects is prevented, and supine and erect posture, it is even because of hemodilution there is the pregnant women is not that causing discomfort to the pregnant women. Now leukocytes, what happens? It is leukocytosis till 8,000 to 20,000 per cubic mm. And immune system, increase humoral and innate immune system. The cell mediated immune system is given rest. Okay, so in pregnancy the humoral and innate immune system responses takes up the charge. Now total protein, what is the total protein? 180 to 230 gram it is increased. Plasma protein 7 gram to 6 gram. This comes under the metabolic changes. Albumin 4.3 to 3, globulin 2.7 to 3. So you have to understand albumin globulin ratio. It is from 1.7:1, it is becoming 1:1. This is an important question. What is the albumin globulin ratio in pregnancy? It is 1:1. So blood coagulation factors. Blood coagulation factors. So hypercoagulable state. So till here, what and all we saw, pregnancy is a hypervolemic state. Pregnancy is a hypercoagulable state, and pregnancy is a hemodiluted state. There is hemodilution. And here fibrinogen is increased to 300 to 600. ESR is raised to 40 mm per hour. And platelets, there is thrombocytopenia, gestational thrombus. You should remember. So all are raised, but whereas platelet is reduced. Fibrinolytic activity is depressed till 15 minutes after delivery. And why there is hypercoagulable state? Why? Because there's some there is severe bleeding that occurs, and to prevent the bleeding, so that the pregnant state is preparing so that there is no severe bleeding during the placental separation. So these are important. Which are the high clotting factors in pregnancy? It is 10, 9, 8, 7 and 1. Okay, 2, 5 and 7. 2, 5 and 7. There is no change or mild increase. This is the most important. Which reduces? This is a frequently asked question. Which clotting factor reduces during the pregnancy? It is 11 and 13. 11 and 13. Plasma thromboplastin antecedent and fibrin stabilizing factor. So factor 1 increases. So factor 2, again, there is no change. There is no change. And factor, no change or mild change. And factor 3 also, it is rising. Okay. And factor 4 and factor 4, it is also rising. Factor 5, there is no change. Factor 7, it is rising. Factor 8 is rising. And factor 9 is rising. Factor 10 is rising. Whereas factor 11 and 13, it is decreasing. It is decreasing. Just remember. And factor 12, there is no much change. So these changes you have to remember. And the main question is, which factors decreases, clotting factors decreases during pregnancy? It is 11 and 13. And clotting time, but there is no change in clotting time. And normalized coagulation factors, when it becomes 2 weeks after the postpartum, it gets normal. Cardiovascular system, what are the changes? So apex beat, the normal apex beat is in the 5th intercostal space and mid-clavicular line, and medial to mid-clavicular line. Now, heart is pushed because of the enlarged uterus. What happens? Heart is pushed upwards and outwards, and that is why a pregnant woman can feel palpitations, especially when the pregnant woman is lying laterally. And then apex beat. When heart is pushed, the apex beat is pushed to a different site, and that is fourth intercostal. It is pushed upwards. So fourth intercostal space. This is also an important question. So apex beat is felt in pregnant women in which space? Fourth intercostal space, 2.5 centimeter outside the midclavicular line. Okay, so usually it is felt medial to midclavicular line, whereas in apex pregnancy it is 2.5 centimeter outside midclavicular line. Pulse rate is high. There is extra systoles. Systolic murmur is seen, especially apical or pulmonary area, and there is something called mammary murmur. Mammary murmur, it is a continuous hissing murmur which is produced in tricuspid area. And why this occurs? This occurs because of increased vascularity in breast or mammary. Okay, and then third heart sound or fourth heart sound may be heard. Why the question mark? Because may be heard. It is not always heard, may be heard, and that is why these changes are important, to know the pathological changes in pregnancy, CVS, and why this changes occurs usually in a pregnant woman. Yes, this is a physiology. In a normal heart, this changes the heart is capable to cope up with these changes, whereas an abnormal heart will not be able to cope up with these changes, and that is when the pathology sets in, or you will get to know the symptoms in a patient, in a pregnant woman. Now, cardiac output. So we saw pulse rate is high. So when pulse rate is high, stroke volume is also high. And cardiac output is stroke volume into the heart rate. And that is why cardiac output is increased. Cardiac output is increased. So fifth week, it starts rising, and 40 to 50% rise by 30 to 34, and it becomes static that thereafter. So low, when does the cardiac output becomes low, or it shows low, it is sitting or supine position, and it shows high in right or left lateral or knee chest position. 50% during labor it increases, and 70% of cardiac output increases immediately after delivery. And there is auto transfusion of blood from the placenta to the mother. So there is reverse auto transfusion from placenta to the mother, and that is why there is 70% increase immediately after the delivery. And high blood volume is there. Why? Because there is high oxygen demand. From whom? It is from the fetus. So stroke volume is also high by 27%, and pulse rate is high by 15 beats per minute. BP is normal or decreased. Usually it is a hypotension state. Hypotension. So BP is usually hypotension. Why? Because there is systemic vascular resistance. So there is systemic vascular resistance. There is BP is reduced, and which comparatively among the diastolic or systolic is reduced. It is diastolic is reduced drastically. Okay, and mean arterial pressure is also reduced, and venous pressure. Antecubital venous pressure is normal. Femoral venous pressure is high. Femoral venous pressure is high, and that is causing edema. Why? Especially on the right side. Why? Because there is pressure, and then it is ameliorated by the rest. Central hemodynamics, the central venous pressure, mean arterial pressure, and pulmonary circulatory wedge pressure. So normal, it is normal, and SPR low, SPR and PVR, colloidal osmotic pressure. So there is pulmonary vascular resistance and systemic vascular resistance. So this resistance, when it comes, it is low. It is low. That is why there is hemodilution, and that is why there is hypotension. Next, supine hypotension syndrome or postural hypotension in a pregnant woman, it is normal. So compression, what happens? The growing uterus, the enlarged uterus will compress the inferior vena cava, and also because of that compression, there is a tendency for collateral circulation paravertebral by the paravertebral and azygous veins, especially felt on the lateral position. So when there is compression, there is reduced blood supply, and that is why the hypotension is seen when there is when the pregnant woman lies on a lateral position. Next, regional blood flow. Uterine blood flow is increased to 750 ml from 50 ml near term. Vasodilatation is there. Pulmonary blood flow is raised to 2500 ml per minute. Renal blood flow is also raised. Skin and mucous membrane 500 ml per minute by 36th week. And that is why in the last term, the pregnant woman's feels heat sensation, sweating or stuffy nose because of the raised blood flow. Next is metabolic changes. General BMR, basal metabolic rate is raised by 30%. Protein, what happens to protein? Positive nitrogenous balance And placenta, the contribution is placenta is gains around 500 gram and maternal 500 gram, and this is distributed especially in the breast and uterus. And urea is reduced because the amino acids are not absorbed. So urea is reduced by 15 to 20 milligram %, and pregnancy is an anabolic state. It is not a catabolic state. It is an anabolic state. Amino acids, there is active transportation, but it is not getting converted into urea, and that is why it is reduced to 15 to 20 milligram %. Fat, 3 to 4 kg increase. I told you in the weight gain, the major contribution is from the fat. More than protein, it is from the fat. And plasma lipids and lipoproteins are increased. And when it comes to lipid, HDL is increased, LDL is increased, and total lipid is increased. Triglycerides is increased. So whenever there is a hypertriglyceridemia, we always, what we think, we have always in a patient, we think the risk of atherosclerosis. But whereas pregnancy is a non-atherogenic hyperlipidemia. Even though the lipid is increasing, it is not atherogenic. There is no formation of any embolus or thrombus. So it is not atherogenic hyperlipidemia. And placental steroidal synthesis, for that, LDL is used up. Even though the LDL rises, the LDL is used up for the placental steroidal synthesis. And there is leptin, which increases the fat. Fat regulation is maintained by the leptin, and this is a enzyme produced by the placenta. Next, carbohydrates, again high glucose. Why? Because there is increased demand for the fetus. And insulin is high. There is hyperplasia and hypertrophy of beta cells, which is the secreting cells of insulin. Sensitivity of insulin receptors is decreased. Why sensitivity is decreased? So that the fetus can take up more glucose, so that the mother is not consuming the glucose which is produced. And plasma insulin is high, and then continuous supply of glucose to fetus is there, which is very much needed so that the fetus is continuing to grow. And there is lipogenesis, and then maternal fasting occurs. In maternal fasting, when the mother is not taking anything, or the pregnant woman is not taking anything, there is hypoglycemia, hypoinsulinemia, hyperlipidemia, and hypoketonemia. And then what happens in fasting? So when carbohydrate metabolism is asked, fasting, it is hypoglycemia. And why? Because during fasting, the glucose is taken up continuously by the fetus. So there is hypoglycemia. And once postprandial, once food is taken, there is hyperglycemia because of the increased insulin, and hyperinsulinemia. And glycosuria is seen in pregnant women. Gluconeogenesis and glycogenolysis also occurs. Even though the lipid is more, it is converted into glucose. Next, iron. Next is iron changes, a very important change. We all know iron supplements are given. So the requirement of iron in total pregnancy is 1000 milligram, and it is highest during the 3rd trimester. And fetal and placenta contributes, or iron is taken up around 300 milligram. Red cell mass 400 milligram. Amenorrhea 300 milligram, because there is no loss of blood during the pregnancy, and that is why 300 milligram is stored, and 200 milligram is lost every day, and total 700 milligram is lost permanently during the whole pregnancy. And daily requirement is around 6 to 7. If iron supplement is not given, it is a pregnancy normally is a iron deficiency state. Okay, so why? Because iron is continuously taken up by the placenta and fetus for the maintenance of the nutrition, and that is why iron deficiency state, and that is why supplementation of iron becomes important in pregnancy. Next, systemic changes. Respiratory, there is elevation of diaphragm. Why? Because of the enlarged uterus. So 4 centimeter. So the breathing becomes diaphragmatic. The breathing is diaphragmatic, and total lung capacity is reduced by 5%, and total residual capacity is reduced. And subcostal angle, this is degree, 68 degree, it becomes to 103 degree. And mucosa of the nasopharynx has hyperemia and edema, and that is why, because of the diaphragmatic breathing, and along with this, the pregnant women feels dyspnea sometimes. Okay. Not very severe, but sometimes feels dyspneic, and increased tidal volume. There is hyperventilation, and partial pressure of carbon dioxide from 38, it reduces to 32, and of oxygen from 95, it increases to 105. Oxygen is always increased by because oxygen demand is increased by the fetus. And respiratory alkalosis. So pregnancy is a respiratory alkalosis state. Base high by 2 MEQ per liter, and maternal oxygen high is by 20 to 40%. Next, urinary system. The dilatation of ureter, renal pelvis, and calyces occurs. Kidney, 1 centimeter increase in the kidney length. Renal plasma flow is increased. We saw that in regional blood flow. And then GFR, glomerular filtration rate, is increased by 50%. And that is why there is no reabsorption of creatinine. There is no reabsorption of creatinine, blood urea nitrogen, and uric acid, which is reduced. And ureter, so in urine, it is not gone out. So that is why creatinine, blood urea nitrogen, and uric acid, it is reduced because GFR is increased. Ureter, atonic, and atonic because of progesterone, which is wherever you see atony or there is relaxation, the hormone there which comes there is progesterone. And wherever there is stasis or where there is contraction, the hormone that comes is estrogen. Dilatation above the pelvic brim, right side. Why right side? I told you the uterus is dextro-rotated, and that is why it causes compression of right ureter. Hypertrophy, again, there is elongation, kinking, and outward displacement. Next, bladder, again, hypertrophy and congestion. Bladder mucosa becomes edematous, especially in the later pregnancy. And micturition, frequency is increased, especially in the early weeks, and then it comes to normal, and then normal or reduces, and then again it increases in the late pregnancy. Increased by 6 to 8 weeks, normal after 12 weeks, and late pregnancy it is again increased. And there is stress incontinence, especially in the later third trimester because of the growing uterus. Next, alimentary system. There is GIT, bleeding and spongy gums because of the hyperemia. Tonicity and motility of the GIT is entirely reduced. Why? Because progesterone. And then why? And when this reduces, there is more absorption. Why we need more absorption? So that the glucose is produced after eating food, and this glucose is going to whom? It is to the fetus, and that is why this is happening as a physiological change. And cardiac sphincter is relaxed. So when cardiac sphincter is relaxed, there is chemical esophagitis and heartburn, which is felt by the pregnant women, which is normal. Pelvic ulcer disease risk is reduced. Why? Because the food goes is absorbed and it is digested slowly. So frequent eating is not needed, and that is why pelvic ulcer disease is reduced. And there is reduced gastric secretion and delayed emptying. So this is one reason why pelvic ulcer disease risk is reduced. And there is constipation. Why there is constipation? In reduced tonicity and motility of the alimentary canal, and that is why constipation is common in pregnancy. Next, liver and gallbladder. No histological changes, no much change in the liver and gallbladder. Depressed function, and LFT is normal. So LFT biochemically or serum, everything is normal. Mild cholestasis occurs, and that is because of estrogen effect. And then atonicity of gallbladder occurs, and that is because of progesterone effect. And high blood cholesterol level occurs because triglyceridemia is there, but this doesn't cause any problem to the pregnant women. And there is increased risk of cholelithiasis during pregnancy because of atonicity and high blood cholesterol. So there is accumulation and formation of stones. So cholelithiasis risk is high in pregnant women. Next, nervous system temperamental changes, the mood swings, the postpartum blues or the depression or psychosis. These are all common in few pregnant women or postpartum women. And nausea, vomiting, mental irritability, and sleeplessness, all because of the hormones that is influencing. And carpal tunnel syndrome, because there is median nerve compression, and that is why carpal tunnel syndrome is common or a physiology in pregnant women. And lateral cutaneous nerve of the thigh is compressed, which causes paresthesia sensory loss in the anterolateral part of the thigh. Next is locomotor or calcium metabolism. 28 gram increase in demand of which? Of calcium. Okay, and then 1 to 1.5 gram daily requirement is needed. Maternal total calcium level reduces in pregnancy state, and calcium absorption is increased. How? Because there is 1.25 dihydroxy vitamin D3 is increased. That is why absorption is more, and then increased calcitonin is also there. That is why parahypothyroidism is not seen. Parahypothyroidism is not seen, and there is no osteoporosis seen in a pregnant woman. Why? Because this is the physiology that is happening, and there is increased mobility of pelvic joints. There is lumbar lordosis because of the grown and enlarged uterus, and also waddling gait and low backache is because of the enlarged uterus. So these are the physiological changes. I suggest all the aspirants to go through all the changes, especially from the source book. This topic, I suggest all the aspirants to go through the source book completely.